Thank you very much. I took this photograph last week when I was at a function of our Museum of Contemporary Art. And when I look at the photo, I realise how privileged I am to live and to work on the traditional land of the Gadigal people of the Eora Nation. And now that I'm in your beautiful city of Auckland, I would like to pay my respects to the traditional owners of the land on which we meet. Now, I need to start with an apology that I'm a paediatrician, not a drug and alcohol person, so I'm sure you know a lot more than I do, but it's been fabulous to sit here and realise that we deal with the same sort of themes. And what I'm going to try and do today is give you a bit of an overview of what we've achieved in fetal alcohol spectrum disorder in the last 14 years in Australia. So fetal alcohol spectrum disorder is a tragic consequence of prenatal alcohol exposure, which does have a lifelong impact. And you might ask, well, how is that relevant to me? Well, in your services, I suggest that you're likely to see the mums and dads of children with fetal alcohol spectrum disorder and to see people who have FASD who are now adults. Also, I hope that this talk might provide you with opportunities to recognise, diagnose and prevent fetal alcohol spectrum disorder. But surely you would say Australian women don't still drink alcohol in pregnancy. As Doug SULLMAN said this morning, a glass of wine in a woman's hand is the new symbol of success. And unfortunately, there is a lot of drinking in pregnancy in Australia. The WHO predicts that about 10% of women drink during pregnancy, although this rate varies. Our national household survey in 2016 shows that 49% drank before and 25% after they were aware of their pregnancy. And this is an increase since 2010. And interestingly, it was the older women, the higher socioeconomic status, and the better educated who continued to drink through their pregnancy. We know that alcohol use in pregnancy is common. In a big study we did in New South Wales, we found that 1 in 1,000 pregnant women had an alcohol-related admission during pregnancy, and that for 1 in 5 of these, it was the first time their alcohol problem had been identified, was the day of delivery. We also know that the rates of alcohol use in pregnancy vary. So in one high-risk Aboriginal community where we've done work in Western Australia, 55% of women said they drank alcohol during pregnancy, and this was at high-risk levels. But this is not an Aboriginal problem in Australia. And these are 3 recent studies that we've done. A birth cohort in Victoria, another in New South Wales and Western Australia, and one in Hunter, New England. And basically we're finding that 60% of women are drinking during pregnancy, albeit many of them give up drinking when they realise they're pregnant. But what is worrying is that they're drinking at very high risk levels in that first trimester. So why do women drink alcohol in pregnancy? Well, when we did a survey of women of childbearing age, which was across Australia, we found that 1/3 of them were unaware of the harms to their unborn child. Furthermore, we found that 20% of them said they were tolerant to alcohol use in pregnancy. So if we gave them a scenario of a very pregnant woman getting drunk in the pub, half of them, or 20% of them, said, well, that's up to them. It's a matter of personal choice. Not surprisingly, we found that drinking in pregnancy was not associated with level of education or knowledge of harms. Drinking was strongly associated with this neutral or tolerant attitude to alcohol use in pregnancy, with previous use of alcohol during a pregnancy, with the partner drinking, with smoking, and with currently drinking at risky levels. We didn't have a representative group of Indigenous women in this survey, so we did some focus group work. And Indigenous people tell us that they drink because of the stress from historic trauma and their present disadvantage. And this is very consistent with the data that we saw yesterday from Jane Buxton from Canada. So it's very important when we're dealing with women who are drinking in pregnancy to take a no blame, no shame approach. Research on asking and advising alcohol use in pregnancy shows that health professionals are very reluctant to raise this issue. So while obstetricians will tell us not to eat soft cheese or pate and not to smoke, they are worried about angering or stigmatising or judging women if they ask them about their alcohol use. Many say that they just don't have time to ask and to record, and others say that they don't know how to ask. Raywin Much did a study in Western Australia and found that these were really pervasive problems. So in a child development unit where kids are presenting with neurodevelopmental problems, in a single year, not one paediatrician recorded any information about alcohol use in pregnancy. The other problem is that we have guidelines, but health professionals are not aware of what the advice it contains. In contrast, in our survey of women of childbearing age, over 95% of them said they wanted to be asked by health professionals about their alcohol use. They wanted to be advised, and furthermore, they wanted to be advised not to drink during pregnancy. So women want a clear message. And yet, the question that I get asked most often is, how much can I safely drink? So what should we advise? Well, we do have guidelines. The NHMRC guidelines, and I know some of you are on this committee with me, suggest that for women who are pregnant or planning a pregnancy, not drinking is the safest option. We know alcohol does harm, but one of the problems is that these guidelines have been poorly disseminated and are poorly recognised by many health professionals. We have guidelines from the WHO which give the same message, and again, I know some Australians were involved in developing these guidelines, and they suggest that we ask all pregnant women about their alcohol use and that we provide the appropriate treatment and referral. And in a study that I'm involved in at the moment with Adrian Dunlop and others in the Hunter, New England area, we've actually embedded the Audit C into the electronic maternity records. And not only do we allow people to identify the level of risk, but we then provide them immediately with the pathway for referral and treatment. And NDARC has also developed this book on supporting pregnant women who use alcohol and other drugs, which I'm sure some of you have seen. So does alcohol use in pregnancy really matter? Well, we know alcohol is neurotoxic, and we know it's teratogenic, and we know that any child is potentially at risk. We have a drinking culture, we've heard about that all week. We know there's binge drinking in teens and increased rates of binge drinking in women. And we know that in Australia, about 49% of pregnancies are unplanned. And I've just told you that alcohol use in pregnancy is common. So alcohol, as you know, crosses the placenta readily, and the peak maternal blood alcohol level equilibrates to the fetal alcohol level. However, harm depends on a number of factors, not only dose, frequency and timing, but a whole range of maternal and fetal factors. And we heard this morning that there are now 300 to 400 genes for alcoholism. However, there are other factors that are also important: the age of the woman, the body composition, and perhaps external factors which we know affect epigenetics, stress, diet, and other drugs. And I put this slide up to remind you that in the days when I was getting pregnant, we thought the first trimester was the damaging time. And of course, the first trimester is the trimester in which all the bodily organs are forming. And hence, if you drink alcohol, you may end up with a child with birth defects. But the brain continues to rapidly develop through the second and third trimester. And we know that even drinking in the third trimester can have substantial effects on neurodevelopment. Alcohol, of course, harms the woman and the baby in the pregnancy. And we know that alcohol use is associated with late booking, low APGAR scores, need for neonatal intensive care. It's also associated with prematurity, spontaneous abortion, stillbirth, and low birth weight. And I put this slide up to remind you that alcohol can damage the child without causing fetal alcohol spectrum disorder. And we know from large data linkage studies in Western Australia that alcohol exposure in pregnancy is associated with birth defects, cerebral palsy, language and intellectual delay, SIDS, somatic complaints, disability, microcephaly, and later in a child's life, contact with child protection, justice, out-of-home care, poor school attendance, and poor academic outcomes. So really, fetal alcohol spectrum disorder is just the tip of the spectrum. So what is fetal alcohol spectrum disorder? Well, it is an acquired brain injury with lifelong consequences. Fetal alcohol syndrome, which you might be better aware of, was described by Ken Jones in 1973, and he described a group of children who were born to alcoholic mothers who were small, had funny-looking faces, had birth defects, and subsequently developed poorly. But we now know that this is a spectrum of disorder and that those birth defects and growth defects will only occur in a small proportion of children. As I explained, the brain may be damaged throughout pregnancy. Alcohol can cause severe structural damage to the brain, as is evident in this photograph, but much more often the brain looks normal, but there are behavioural, learning and developmental difficulties. And this is the sort of child that commonly presents to my clinic in Sydney, and his father's given me permission to tell his story. So a 3-year-old boy, alcohol-dependent mother, who in fact now has died from her alcoholism, born preterm and low birth weight, irritable, slow speech, slow development, squint, emotional lability, attention deficit hyperactivity disorder, risky behaviour, expelled from preschool, and many of our patients are expelled from preschool, failing in primary school, had microcephaly and typical facial features. So one does wonder, what is the future for a child like this? Now, I mentioned that fetal alcohol spectrum disorder has got lifelong implications, and what we do know is that when these children grow up, they are at increased risk of mental health problems and substance abuse. They're at increased risk of sexuality problems, unemployment and dependency. We know that this is a huge social and emotional burden on families and communities, but it is also a huge financial burden, this estimate of up to $10.5 billion per year in Canada. And more recently, we're learning that the mortality, the average rate of death, age of death is 34 for people with fetal alcohol spectrum disorder. Many of those deaths are due to suicide, accidents and poisoning. We know from recent data in Australia that 1 in 3 children in youth detention in Western Australia have fetal alcohol spectrum disorder. But we're also learning that as these children grow up, they seem to have higher rates of organic disorders, particularly autoimmune, respiratory, endocrine and other disorders. And there's a big study in North America going on at the moment. Is this due to priming in pregnancy? Is it an epigenetic effect? We also know that the outcome for these children as they grow up is determined in part by the environment in which they're raised. And we know that adverse childhood experiences, whether abuse, neglect or household dysfunction, can influence outcomes. But we know that those outcomes can also, those exposures can also influence harmful behaviour and poor health outcomes. So it's always important in these children to consider what sort of environment they are living in. So how is the diagnosis made? Well, until recently we had no guidance in Australia, but we were funded by the federal government to produce the Australian Guide to the Diagnosis of Fetal Alcohol Spectrum Disorder, and I understand there's a similar guide available in Australia. We require for the diagnosis evidence of prenatal alcohol exposure, severe neurodevelopmental impairment, plus or minus facial and other physical features. And of course, we have to exclude differential diagnoses. Prenatal alcohol exposure, we like to get that information from an Audit C, but seeing up to maybe 70% of the kids that I see in my clinic are in foster care, often we're trying to get information which is not nearly so precise from police records, docs records, maternity records, etc. I mentioned the characteristic facial features, and if you just look at your neighbour, you're looking out for a very narrow upper lip, an indistinct philtrum, so lack of that grooving between the nose and the upper lip, and narrow eyes. But don't be alarmed unless they've got all 3 features. Or more, oh right, or more, but he's hiding it with his moustache. More importantly, you know, they really need to have severe neurodevelopmental impairment. But what's interesting is that this phenotype, the 3 sentinel facial features, you can see hold fast whether the child is Hispanic, Caucasian or Afro-Caribbean. When we're looking at neurodevelopmental impairment, we look specifically at these 10 domains of function. Now, they are somewhat arbitrary, but we're looking for severe impairment, so 2 or more standard deviations of performance below the norm. And really, if you're looking for this sort of degree of assessment, you need a multidisciplinary team. So there are challenges in making this diagnosis. And of course, there is some scepticism still about the diagnosis. There is no diagnostic test, and often these children are missed. But increasingly, with the resurgence of epigenetics, genetics and 3D imaging, we may be getting closer to finding other biomarkers that can help in the diagnosis. From your point of view, one of the things that we often lack is a record of alcohol misuse or intake prior to or during the pregnancy. So it's really good to have that clearly recorded. Till recently, we've had no guidelines and limited services. We have few trained clinicians, and many of them don't know how to make the diagnosis or are worried about stigmatising families. There is some overlap between the facial features and other syndromes, such as dilantin exposure. And of course, these conditions can have comorbidities and confounding by other contributors to neurodevelopment, such as the early life trauma that I've mentioned. So we always look at chromosome microarray, for example, in these children, thyroid function, iron and lead levels. I've been involved in some work run out of the Murdoch Children's Institute in Melbourne, where we're using 3D imaging to look at a cohort of children at 1 year of age who we had recruited early in pregnancy. And what we found was, using this very sophisticated imaging, even at low levels, prenatal alcohol exposure can influence craniofacial development, and that these faces in children who were exposed to alcohol were significantly different to those who were not exposed. And I think this and other biological markers will help us in the future. I'm fortunate to work with Poppy and Bronwyn, who are in the front row here, at the Cicada Centre in New South Wales. What we've done in this centre to deal with the diagnosis is to combine several clinics. So we have a fetal alcohol spectrum disorder assessment clinic combined with a family service for children living in households with drug and alcohol use, and an adolescent service for children who use alcohol. So why should we make this diagnosis? Is it worth bothering? Well, even if the diagnosis is never reached, the assessment process does identify the strengths and needs of children, and it enables us, parents and teachers, to understand the child's capacity and adjust our expectations. It also, of course, helps guide intervention, and the earlier the better. It enables families to access financial support, and importantly, from your point of view, it allows treatment of the mother's alcohol problems and may prevent a future child being born in that family. So what do parents say? Well, they think it's very important to understand that the child's behaviour is a result of brain damage, not willfulness, that it often alleviates their guilt about poor parenting, that it allows them to network with other families who are similarly affected. We now know that FASD is recognised as a mitigating factor in the criminal justice system, so that can be helpful. And individuals who have the diagnosis say it makes them feel better, knowing that their struggles are not their fault. But how prevalent is fetal alcohol spectrum disorder? Well, we have some global data again from the WHO suggesting that there are 8 cases of fetal alcohol spectrum disorder per 1,000 population, or over 600,000 new cases per year, and that this is now the leading cause of intellectual disability and birth defects. We have very poor data in Australia. We are currently collecting some incidence data through the Australian Paediatric Surveillance Unit, where every paediatrician every month gets mailed a little card and reports to us whether or not they've seen a child newly diagnosed with fetal alcohol spectrum disorder. We've had a significant number, over 200 cases, since we started the study. Mean age of diagnosis is about 8 when these children start to struggle in primary school, but the majority of cases are being reported by a very small number of paediatricians working in specialised clinics. About 60% of kids are Aboriginal, and many of them come from Western Australia. But in this sample, 24% of the children have microcephaly, head circumference less than the 3rd centile, so significant structural brain abnormality, and they are significantly impaired, particularly in executive functioning, adaptive behaviour, language, attention and academic achievement. Now, when we look at these kids, 40% of them were exposed to high-risk alcohol levels. We don't have Audit C data on all of these, but it's either high Audit C scores, more than 7 drinks a week, or binges. 41% were exposed to alcohol only, but 59% to alcohol plus other drugs. 75% of these children have been in child protection. Over a half live in out-of-home care. Few live with their biological parents, and 15% of them have a sibling with fetal alcohol spectrum disorder. So this is the situation in reports of fetal alcohol spectrum disorder seen and reported to us by paediatricians in Australia. But we know that there are pockets where there are very high levels of fetal alcohol spectrum disorder. And the only population-based prevalence study that's been done in Australia was done in the Fitzroy Valley in Western Australia. In 2006, this community was in crisis with alcohol-related deaths, murders and suicides. The women decided enough was enough, and they lobbied for alcohol restrictions, so that in Fitzroy Valley to this day you can only buy low-strength beer to take out. You can't buy mid or high-strength beer, wine or spirits. Having put in place these alcohol restrictions, they looked around and said, why are our children struggling at school? Why are there behavioural problems? Why do they look funny? Could this be fetal alcohol spectrum disorder? And they developed a strategy to address the diagnosis and prevention of FASD and the support for parents and families. And they call this strategy Maralu. Maralu is a word in the Bunaba language, one of the 5 languages of the Fitzroy Valley, which means precious, worth nurturing, which is what they feel about their children. Now, the Fitzroy Valley is located a long way from Sydney, and we were very privileged to be asked to work up there and have worked up there really since 2009. It's a beautiful place, and they asked us to do a prevalence study of alcohol use in pregnancy and fetal alcohol spectrum disorder. They call this the Lililwan Study, Lililwan being a word for children, all the little ones in Kimberley Creole. June Oscar, who was one of our investigators on this study and is now our Social Justice Commissioner at the Human Rights Commission for Aboriginal and Torres Strait Islanders, described fetal alcohol spectrum disorder as a tragedy that somehow transcends other aspects of grief and trauma. Here is innocent young life, the future of our people, our culture, our language, knowledge about the magic creation and laws of our land, who are being born into this world with brains and nervous systems that are so impaired that life for that person, from birth to death, is cruelly diminished. June described fetal alcohol spectrum disorder as a humanitarian crisis, and she, like most grannies, people my age working and living in Fitzroy Crossing, are looking after children with this disorder. So we took on the challenge after a long consultation with the communities. We assessed alcohol intake in all the mums of 2 age cohorts in 54 very remote communities in the Fitzroy Valley, using photographs of the available grog and using the Audit C. And what we found was that about half those women shown in green didn't drink alcohol at all. Those who did drink had Audit C scores 9, 10, and 11, 12. And what that really means in this community is that a significant portion of women drank 10 or more drinks on a daily or almost daily basis, 2 to 3 times a week, or once every 1 to 2 weeks. So although half of them weren't drinking, those who were drinking throughout the pregnancy at high levels. Then we went back the next year and we did a multidisciplinary examination of all the children in this cohort. We analysed their face using some photographic analysis software developed at the University of Washington. And we were able to establish that the Aboriginal faces can be analysed using Afro-Caribbean normative data. And what we found was that 1 in 5, 19% of these children had fetal alcohol spectrum disorder using strict criteria. And this is likely really to be an underestimate because some assessments couldn't be done in some children. And they really had the full gamut of learning, developmental and behavioural problems, low IQ, mental health problems, and physical problems. But what is also really important is that 100% of these children were exposed to significant early life stress, quite often the sort of stresses that we may never be exposed to, witnessing a murder, witnessing a snake bite, a death from drowning, living in overcrowded houses, separation of parents, father in jail, grog and drugs used in the house frequently. And of course, these are the social determinants of so many of the problems that we see in our Aboriginal communities. Nevertheless, the community proceeded with the study. It was provided the data they needed to advocate for funding for services, etc. And the community was praised for dealing with this taboo subject and said that it did have a lot of benefits, both in the diagnosis and treatment of children, but also in enabling them to get educational support and parent support. It raised awareness of the issue in the community and, of course, built capacity and provided education and training. But they did urge all of us, when we're providing this message, to reinforce that fetal alcohol spectrum disorder is not solely an Indigenous problem, and that it's likely that many of the children that we see with behavioural and learning problems in our community who are not Aboriginal children but exposed to alcohol may have this diagnosis. Now, some of the benefits from this study were the production of educational materials, particularly this film on the right, Tristan, which described the challenges of a little boy living in the community with fetal alcohol spectrum disorder. And we were fortunate to be invited to present that at the UN, at the Permanent Forum on Indigenous Issues, where the people from Fitzroy Valley community realised that this was a problem which is replicated throughout Indigenous communities worldwide. The data has allowed us to support the unbelievable many challenges to the alcohol restrictions which have occurred in the last 10 years. It's prompted the development of educational resources for teachers and alternative pathways of education, so teaching children to be baristas, teaching them gardening skills, fencing skills, giving them some alternative to achieving academically. We have recently been trialling an intervention led by James Fitzpatrick of a program in schools to help children with impulse control. The results are not yet published. And we've also put in place a positive parenting program to help parents deal with these really severe behavioural problems that manifest in these children. But the news is not all good. So several of our children we know have died, including one who died in a car accident in a car driven by another child in our cohort, who then ended up in jail and really being banished from the community. We know that children in our cohort have been involved in theft and trashing the school. And we have been asked to see if we can locate where have these children gone, where have they ended up, why have they not accessed the services that they were referred to. And of course, one of the problems is that there's a complete lack almost of psychiatry, child psychology and drug and alcohol services in these very remote communities. Now, this is a little boy called Tristan, who was the feature of the film that I showed you, and he is currently running a lawn mowing business, so he has only an IQ of 60. He doesn't read and write, but his father is supervising the appointments and the financial matters, and he, of course, does a very good job doing the lawns for a whole lot of people around Fitzroy Crossing. So what other translational impacts have arisen from the work that we've done? Well, politician Sharman Stone became very interested in this Lililwan study, and although it was really a very small study, it did capture the attention of politicians. And she initiated an inquiry into fetal alcohol spectrum disorder in Australia, and of course we contributed to that. But as a result of that inquiry, there was a federal government national action plan to reduce fetal alcohol spectrum disorder, and that came with, over about several years, 5 years, $20 million. And that, of course, enabled us to fund many of our activities, including the Australian Guide that I've talked about. We have a website which you're welcome to join and give us feedback on for parents and carers, but mainly health professionals, for policymakers and researchers, to a sort of one-stop shop for information on fetal alcohol spectrum disorder. It funded a helpline for the National Organisation for FASD, the Parent Help Group. It funded some information for health professionals, including the Women Want to Know materials, which are available through the Federal Health site, and give training to health professionals on how to ask and advise about alcohol use in pregnancy. It resulted in the development of various resources from New South Wales Health, specifically for health professionals dealing with Aboriginal communities. And it resulted in some health prevention and health promotion resources which have been distributed around Australia, which were developed by the Menzies School of Health Research. We were fortunate also to get some NHMRC funding for a centre of research excellence in fetal alcohol spectrum disorder. And really, one of the other things that we've been able to do, because we've had this centre of research excellence and now have a national group, is to do what John's just been describing, to use the research really to advocate. So there have been a number of inquiries now. We don't need any more inquiries, we need action. However, these inquiries have enabled us to advocate for mothers and children. Inquiries into fetal alcohol spectrum disorder in the Northern Territory, inquiries into alcohol advertising in New South Wales, the Senate inquiry, which you may have heard about children in juvenile detention. And at that hearing, it was pointed out that many of these children have fetal alcohol spectrum disorder. We've also been able to advocate for inclusion of data in and changes to various guidelines, the pregnancy guidelines, the AMA position statement, the College of Physicians alcohol policy, the NHMRC and WHO guidelines, a charter for the prevention of FASD, and more recently, the push for labelling of alcohol beverages. And we've also, of course, been invited to participate, as I know many of you in the room have, to various roundtables. I'm not sure how much they listen to us, but we are able at least to have a voice. There is currently, as you I'm sure know, a national FASD strategy being developed and a national alcohol strategy. So back in 2004, Carolyn Bauer and I wrote an article which was called Fetal Alcohol Syndrome in Australia, Fact or Fiction. And at that time, there were about 12 publications. We now have from the Australian group about 150 publications relating to fetal alcohol spectrum disorder and alcohol use in pregnancy. And I hope I've illustrated that there has been some translation of this research into both clinical care and policy. But we are left with a number of challenges. One is the media. So whenever anything comes out about fetal alcohol spectrum disorder or alcohol use in pregnancy, we're challenged. Mum insists that drinking during pregnancy is fine. Furious partner is accused of overreacting. Rules on how to behave in pregnancy diminish women's freedom. Advice to pregnant women on drinking is patronising and sexist, etc. So we're really up against entrenched attitudes and intolerance to change when it comes to our behaviour. This has been mentioned a few times at the conference, but young women are targeted by alcohol advertising. This particular one advertised a low-cal vodka cruiser, and you got the free offer of free condoms and the chance to win a pole dancing kit if you bought that particular alcohol. Fathers, of course, remain a challenge, and the Foundation for Alcohol Research and Education has launched a campaign, the Pregnant Pause campaign, where they're trying to persuade men that they should abstain from alcohol when their wife or partner is trying to get pregnant or during the pregnancy. Now, there's been a lot of discussion, and I particularly enjoyed Peter Adams and Doug SULLMAN's talk about the unhealthy commodity industry. And Peter mentioned these social aspects and public relations organisations and mentioned Drinkwise as one of them. They are organisations which are said to be independent non-profit organisations. They're aside from but funded by alcohol industry profits. And we've had a few dealings with them recently. So the first one was that Drinkwise, unknown to us, developed some posters which they distributed to hundreds of medical surgeries. And the headline was quite consistent with our guidelines, that it's safest not to drink while pregnant. However, the next line, which is in very small print, said, "It is not known if alcohol is safe to drink while you're pregnant." So after a flurry of activity really led by FARE, who, like many of us, think the alcohol industry has no role in the public health information space. These were all withdrawn and replaced with new wording. And the AMA was very supportive in stepping in as pregnancy posters were pulped. And then the second thing that Drinkwise were involved in, as you can see, Greg Hunt, with a prominent Aboriginal actor, was to develop some little videos advising about alcohol use in pregnancy, in which our Minister for Health is photographed in front of the Drinkwise banners. Recently, we've had some success in the decision that warning labels for harms from alcohol use in pregnancy will be mandated in Australia and New Zealand. And one of your colleagues, Christine Rogan from Alcohol Health Watch, says that after decades of this fight, the wellbeing and future of generations of Australian and Kiwi children has finally been put ahead of the alcohol industry profits. Now, this is really a small win, but there's no doubt that these labels do raise awareness, whether or not they change behaviour. However, the next battle is that Drinkwise think that they, as the industry, should be the ones to determine what sort of labels are on these bottles. And as you can see, the existing labels are extremely small, black and white, don't provide any information, but do refer people to the Drinkwise website to get the facts. So my take-home messages. Alcohol use in pregnancy is common and it is harmful. The outcomes are unpredictable because there's a complex interaction between alcohol exposure, maternal and fetal genetics, and the pre- and postnatal environment. Fetal alcohol spectrum disorder is a form of acquired brain injury. It's the most common cause of disability. It is a preventable tragedy, and yet it has lifelong implications. But the brain is plastic, and if we can diagnose and intervene early, then there is a chance to improve outcomes for these children. And of course, Doug SULLMAN's 5+ strategy is really needed to underpin efforts to decrease drinking in the community and hence in pregnancy. This is a little advertisement for our conference, which is coming up this month in Perth, if anyone happens to be still interested in attending that. I have to acknowledge the many people that I've worked with over the last 10 years on this issue, and of course the funding bodies who we're dependent on for our work. Thank you very much.